Is on the inauguration ceremony and Aishwarya Rai Bachchan.
Yeah.
But I would like to speak on this topic because I was given this opportunity. The chevron incision in SICS, you have to understand we get a huge volume of patients and mostly advanced cancer. I'm the head of glaucoma and AIOC2022 Rohtak. Whenever I see someone standing here, I wonder why them and why are they speaking on this. So normally you have to have some experience behind you. I got from MBBS days, I was interested in ophthalmology. So in CMC Vellore, I got the Victor Rambo Prize and I had just one interest. After that, I have been a consultant in AIOC2022 Rohtak. I have been performing and teaching SICS for over 20 years and a reviewer for several journals. SICS is here to stay. It is there in developing nations as well as developed nations. It's affordable, safe, and effective. And we had the major problem of people asking about the capsulorhexis and about surgically induced astigmatism. Why is surgically induced astigmatism important? Because uncorrected visual acuity, which the patient wants, is best with minimum SIA. So the cost of equipment is minimal. We have minimal facilities with maximum patients. So we found that this is a good treatment option for them. It has a shorter learning curve. And for all our camps and high volume setups, it is the surgery of choice. So there is a self-sealing incision with a tunnel. There is also simulation brace training available. I brought my postgraduate students to Mumbai in December 2020 amid the pandemic, and they underwent a 1-week training. I was there for 3 weeks. I saw that the simulator is extremely effective. I asked them when they came back, they did much better surgery when they came back. So incisions are a key factor. This is my typical tunnel. I have never made the straight tunnel. I started with the frown-shaped tunnel because they said it was better than straight. So I said, why not start with something that is better? And after that, I immediately went on to chevron, and I've been doing that for over 20 years. I have publications in this and one in the pipelines. So irrespective of, if the patient does not have too much of preoperative astigmatism, you do not need to do on axis. That is the advantage of this. So in our published study, in the frown group, the astigmatism was 0.82 plus minus 0.62. In our chevron group, it was 0.55. Because I'll show you videos, it comes within the astigmatic neutral funnel. In our latest study, which is as yet unpublished, it has come down to 0.32 diopters, plus minus 0.27, because I'm going further away from the limbus now and making it steeper. So all the studies show that the chevron, this is a typical patient of ours, 78-year-old, hypermature cataract. Later on, you'll be able to see the calcific spots on the anterior capsule. So this is, I'm using an instrument which costs 30 rupees. The total cost of the surgery is sometimes less than $5 US, sometimes less than $10 US. So this gentleman, of course, was of a low socioeconomic status, but as important as any other patient. And of course, staining, like Sir said, staining really helps. And I attempt to do a rhexis in all patients as CCC. Whether it is you can see the fluid, and then you put just a normal viscoelastic. We do not have access to the higher molecular weight. And you can see now all these calcific spots on anterior capsule. Again, hard nucleus. So you're trying to rotate it into the anterior chamber, irrigating via vectors to deliver this. I'll show you the post-op pictures also later, and at the end of the surgery. Another person with hypertension, the same. I'm just showing you the tunnel. So not too much cautery, not too little cautery. It has to be ideal. Instruments are very simple. The surgery is gives good results. It's simpler than a lot of, and instrumentation, cost of equipment, and every patient you're using disposables. It provides good results. So you have to do the best you can do and the best for the patient. This is my typical tunnel. I'm just showing you enough tunnels. This is another 60-year-old with hypertension. And all of them, the chevron. And you can see mostly I get only advanced mature, hypermature, brown cataracts. So sometimes you come across a blunt scleral blade, but even then you have to be careful. If you put too much pressure, or if you have a premature entry, the iris will keep relapsing, your tunnel won't be good, your astigmatism will be more. And if it is too superficial, then you'll have buttonholing. So what is the ideal? 50 to 70%, 75. I find that with this tunnel, it's easier to use the forceps to complete the CCC. Another patient with hypertension. All patients have comorbidities because the age is more. So the minimums, this V, apex of the V, the minimum distance you should keep from the limbus is 1.5. I'm trying to keep it at 2 nowadays, which apparently is a little more difficult, but I think that it is very doable. So in all of them, that's what the argument was about CCC and about astigmatism. So I've taken a lot of pictures of just the CCC in all these patients, especially in the white cataracts. And a lot of them had rigid indigenous posterior chamber intraocular lens, which were 100 to 200 rupees in cost. This was a slightly younger patient, so I could do visco expression. Another patient with diabetes, just enough to say it's not a one-off. I'm doing this routinely. So this is in every patient with advanced cataract, I try to do the chevron incision. So you can see 2 millimeters from the limbus, and this is the tunnel. In this patient, initially when I started doing chevron long ago, I started making it wider. Now, as you can see that within the funnel, I have made it steeper. This was a surgery from, I'm just showing you the contrast between this and that, the present ones. And again, you can see this keratome, 30 rupees, is a little blunt, but because of experience, you can manage to make a good tunnel. So basically, astigmatically, neutral, or you should provide less than 0.5. Like I told you, our latest figures are 0.32 plus minus 0.27. The blade should be visible throughout. They said like how much scleral depth should be there. So 50 to 75%, moderately visible crescent throughout the surgery. This is the tunnel. So these are the dimensions of the tunnel as measured for you. Again, another white cataract. So my thing is that you never have to convert from an SICS to a phacoemulsification, is what I tell the PGs when they start learning. But you may have to convert from a phaco to an SICS. Rigid, 100 rupees intraocular lens. So these are ideal for our patients. Another 80-year-old patient, again, the rexus can be completed after staining the anterior capsule with the forceps. It's much easier because you already have that opening tunnel, and I try not to make a side port because I feel that I do not want to play with the condylar. As you can see, there is some fluid leakage. Then you can just complete the CCC in these also. I have done a lot of intumescent cataracts and phacomorphic glaucomas also. So always try to do this. I have found that sometimes when residents, when they're learning, when we're teaching them, they tend to make smaller X's, and especially in these hard cataracts, you may have to give relaxing incisions on both sides so that you don't end up with problems. And this is a rigid intraocular lens. This is in a younger means less than 60. In a younger patient, a steeper incision. This video was taken with a phone because, of course, our recording was not working, but that's no problem. So with the phone through the student view scope of the ophthalmos of the operating microscope. So this is the tunnel. And you'll see at the scleral pockets at the edges, almost my whole crescent is being used. So you can easily make out that it is a long tunnel. Advantage here, 4 millimeters, 6.5 millimeters. That's why you're within the astigmatic funnel, and at the same time, in this patient, her preoperative astigmatism was 0.25 with the rule, and induced astigmatism was nil. It was 0. So her post-operative astigmatism was also 0.25 with the rule. She had 6/6 unaided vision. So this is a typical patient when we do it. And these are some, all these patients that I've shown you, post-operative results taken with my phone with a slit lamp, and mean surgically induced astigmatism of this latest series is 0.32, which is comparable to anywhere else or any other surgery. So of course our expectations are this 1-to-1, the doctor's expectation, patients 1-to-1, the patient and doctor, and this is our reality. This bottom right side is an actual picture of our OPD taken 2 weeks ago. This is what we have every day. High volume, lots of patients, advanced cataracts. We also have a series of neglected eyes. Why do they present so late? Because so many of them come with phacomorphic glaucoma. But I'm very grateful and blessed to be where I am because you get to do so much, and again, you do the best you can. I'm still learning. This is this was published in the paper during COVID time, that this is what's happening in the hospital. I'm still learning, and I've learned a lot today. I'm learning to provide quality to quantity. Thank you so much for this opportunity,
Thank you,
sir.
Manisha.
Thank you for having me.
Manisha is the professor in the Rohtak Medical College's Regional Institute, and so many PGs and students that she has already taught, and we are listening her a long time. Thanks, Manisha. Sorry for the confusion, but really we have a nice video. She has been associated with us in SICS, and she has been recently gone to Bombay with her students to learn about the simulator. Good training. You all should go help me see stall or SSC stall. Whoever want to learn the SICS, they have got a very good technique. You will feel that you are live operating in a patient. So everybody should go help me see area or the SSC area.
It's wonderful. It gives such a good feedback. Even I sat at one of the machines. I sat not in front of the PGs, but I want to have a feel. Amazing. Every step of SICS, from the side port onwards, if you put too much pressure, if you go too much tongue, there's a big red light.
And you will also learn where you have done the mistake.
Exactly.
That will show you where you have made the mistake.
Show your replay. And then it's recorded. And the best part, what my PGs found for CCC, as well as for the incision. The simulator is really good. We were there at the international launch, and I highly recommend it to everyone. Thank you.
Thank you.